everybody. I'm Anil Karapurkar. I'm a neurosurgeon. I would like to show a case of stenting of M1. This is a very unusual patient. He was about 60 years old. He had had multiple TIAs of the right face and right hand. He was a known diabetic for many years. He didn't have hypertension. Unfortunately, uh, he was normal on examination, and his blood pressure was 130 by 80. His diabetes was under control. The 2D echo showed no gross abnormality. Unfortunately, his MR findings films are missing, and I do not have his MR. I had directly have his DSA. This was done, I think, in 2002, about 18 years ago. At that time, the quality of the MR machines also was not very good. So this was his DSA. This is the right internal carotid artery. You can see the bifurcation in the neck on the subtracted, non-subtracted views. And this is the down view and lateral view. What is astonishing is the right M1 is totally occluded from the origin. You don't see the right M1 at all. And there is retrograde flow from the ACA into the MCA. The PCA, posterior cerebral artery, is large. So there is some collateral from the posterior cerebral artery. On vertebral artery injection, the PCA fills poorly, and probably the left P1 is thin, the right P1 is thin. So there is very little contribution from the basilar. So the right MCA territory is obviously completely reconstituted by collaterals from the ACA and PCA. This is the left side. On the left side, there is a tight stenosis at the origin of M1. The distal flow beyond is quite good. On this side also, the PCA is large. So the PCA did take over the supply of the patient, of the MCA territory. And since this patient had a very tight stenosis, it was decided to do angioplasty stenting. In those days, the Cypher stent had just become available. The Cypher was a drug-coated stent from Cordis. And so we managed to cross the stenosis. This was a transient 14 wire. And like I told you, this was 2002. I used to always prefer direct angioplasty stenting. I mean, direct stenting without angioplasty. So we used to eyeball what the size of the artery is and use a drug-coated balloon-mounted coronary stent. We had done quite a few by then, and our impression was that the recanalization, I mean the restenosis rate with a drug-coated stent is low. So we would, as far as possible, use a drug-coated stent. So this was a Cypher. As you can see, we've got a perfect position. Again, unfortunately, I do not have his post-stenting pictures, but you'll have to take my word for it that this was a perfect result. So post-operative course was uneventful. And in fact, I think 2002 we had done him. And later, about 5 years later, came back with Parkinsonism. And then he went for physiotherapy to Iyengar. I don't know whether you guys know Iyengar. Iyengar was one of the leading yoga exponents and teachers in Pune. So in fact, he went and learned how to live his life after Parkinsonism. 15 years later, after the stenting, he was doing very well. So this was with a drug-coated stent. So what was unusual was the right M1 was totally occluded, and he never had any symptoms pertaining to the left side of the body. What he had come now with, obviously, ischemia in the left hemisphere with TIAs, hand and face. This is another patient, again a very interesting gentleman, who was 74. In 2002, had acute onset hemiplegia due to this small clot. And he was treated conservatively, of course, for the small clot, and he recovered, but he had a mild left hemiparesis, which was residual. An MRA had been done at that time, and the MRA had shown that there was a stenosis of the left M1, as you can see here. There is a very tight stenosis. This was in 2002. Obviously, the quality of the MR is not very good. So he was started on aspirin because of this stenosis. In March, in the 7th on March 2007, he again had a fall, and his left hemiparesis worsened, and he had this subdural hematoma, acute subdural. So initially they made stop the aspirin, made boreholes to evacuate the subdural. He improved for a few days and again became drowsy. So the scan was repeated, and there was a residual subdural which was now isodense. Earlier it was hyperdense, now it was isodense. So a craniotomy was done and the subdural membrane was excised, but this was done a local anesthesia. And he improved a little bit, but he again started deteriorating, and 10 days later started getting episodes of confusion and aphasia. So this is a new CT which showed that the subdural was almost gone. There is no subdural now. Maybe a thin rim in the frontal area. And the MR also showed just a tiny infarct diffusion method on the left side. You can see it in the bottom right frame where it is marked out by the arrow. So that was a single lesion and probably accounted for his episodes of confusion and dysarthria and aphasia. And this was his MRA at that time on the 11th of March, 11th of April in 2007, which showed that there was no MCA on the left side. So the drowsiness was attributed to electrolyte or to electrolyte imbalance or to infection, and aspirin was restarted. Next day, he developed complete motor aphasia, and MRA was repeated. Now you can see many more lesions in the left central semiovale, and these are watershed. These are ACA, MCA territory. And this is his angiogram, which shows there is a very tight stenosis of the left M1, either a tight stenosis or an occlusion. This is in 7, the image quality of the MR is still very poor. So I was consulted at that time, and I said that these are all hemodynamic, these are watershed, these are certainly hemodynamic, and if you don't do anything, he'll go into an infarct. Everybody dissuaded him from getting anything done. Neurologist, neurosurgeon, everybody said, don't touch him, leave him alone. The son is a spine surgeon, aggressive fellow. So he said, no, you have to do something. We cannot leave him like that. So we took him up. His creatinine was borderline 1.7. So we hydrated him well and then we took him up. So when we took him up, he was responding to pain. He was not obeying commands. The left upper limb, lower limb was weak from before. Right side also was weak now. And he had motor aphasia. But he needed much coaxing to obey simple commands. And this was his angiogram, which showed total occlusion beyond that short stump of M1 and good retrograde flow from ACA to MCA via collateral circulation. And this was coming down almost to the perforators, almost to the point of occlusion. So on the bottom right film, you can see that the retrograde flow from the ACA to MCA is coming all the way down to the Sylvian fissure, almost to the point of occlusion. So the occlusion was a very short segment occlusion. Since he had recently become symptomatic, I felt that we should go ahead and do something. Of course, there was a debate, should we not? But finally, the son said, no, you go ahead, let's do what we can. So there was that short segment total occlusion of M1. So in those days, we used to cross with a transient wire and take a echelon in the transient wire. So accordingly here, we have crossed with the transient wire. We brought the echelon in, and I used to like the stabilizer wire. The stabilizer, the distal tip is very soft and it is just 3 centimeters long. Proximal to below the proximal to the 3 centimeters, the wire gives excellent support. The only guiding catheter we used to at that time was an envoy. So envoy would not go beyond the skull base. Today, guiding catheters can be taken all the way to M1 if required. But at that time, those days, we had to keep the envoy low down at that skull base. So we had to rely on the support that the wire would give. So I like this wire immensely. It was a very good wire giving very good support. So once the echelon was across, we exchanged with a 300 centimeter stabilizer cardiac wire. And on that stabilizer cardiac wire, like I said, I used to like direct angioplasty. So here it is. We've done a direct angioplasty. And look at that artery now. And you can see that we've got a fairly good reconstitution of the M1. And this is his CT post, which shows that we have not introduced any complication. And in fact, he did improve. He was wide awake, he was smiling, he shook hands, he recognized his son. And 4 days later, he was able to walk with support. So he did improve following this. So this was a patient who had multiple problems of hemorrhage. Intracerebral hematoma, then a subdural hematoma, recurrent subdural hematoma on the opposite side. And the M1 stenosis had been diagnosed in 2002, but nothing was done until 2007. And then in 2007, we stented his left M1 with, again, this was a drug-coated coronary balloon-mounted stent. And this was a Zions stent. I don't remember the diameter or the length of the stent which we used at that time, but it was a Zions, as you can see here. This is a balloon-mounted drug-coated stent. So, though he had very good retrograde flow coming down to the point of occlusion, the very fact that he was getting multiple TIAs and there was that string of pearls, the circulation was inadequate. Of course, you can raise the blood pressure, you can control the blood sugar and all that, but still, I thought angioplasty stenting is required because of the hemodynamic effect of the stenosis. Thank you very much for your attention.